Okay, this is your lecture on chapter 13 in your book, and it's going to cover shock. This is a really important topic. It's a short chapter, but it's pretty common, and it's something that nurses need to be really, really aware of, because the most important thing in shock is to prevent it from occurring in the first place. So we're going to talk a lot about the pathophysiology of shock, and then there's about 4 or 5 different kinds of shock. But the underlying pathophysiology is the same in all of them. So we're going to start out talking about the pathophysiology because it's really important that you understand that. And then we'll talk about the different kinds of specific shocks. What you need to know about shock is that there are multiple causes that create this physiological response, and the bottom line is the physiological response is inadequate tissue perfusion. The cells are waiting for the oxygen and the nutrients to arrive, and that's not happening. So then the compensatory mechanisms start kicking in, and if it's not treated and if it's not resolved, then those compensatory mechanisms start to fail, and then ultimately you get to a stage of shock that's irreversible, and it will lead to death. So there are three different stages to shock: the progressive phase, and a compensatory phase, and then an irreversible phase. And we're going to talk about those and what each of those look like. A couple things I want to point out that you might hear. I want to kind of clear this up. Shock is not necessarily the same thing as sepsis. Your patient can be septic and not also in shock. But if the sepsis goes untreated, it then can lead to shock, and then they're in septic shock. So a lot of people in healthcare will, if a patient's in septic shock, they'll just say he's septic. But sepsis and septic shock, technically two different things, but they're kind of closely related. Sepsis is just an overwhelming infection in the bloodstream, and it can be caused from different things. Like, for example, if your patient has a UTI or a renal infection, especially if that goes untreated and it's getting out of control, the patient can develop urosepsis, meaning sepsis, infection in the bloodstream from a urological problem. So you might hear that word like urosepsis. I'm trying to think of another one a word that you might hear, but it is an infection that has started somewhere. It has gotten into the bloodstream, and then the patient is septic. So you still want to treat the sepsis because you're trying to prevent septic shock. So I just wanted to point those out, that those are two different kinds of things. So let's talk a little bit about shock. Keep in mind that there are 3 components to the circulatory system, and it is the pump, this is the heart, the vasculature, the arteries and the veins, and the fluid in them. These are the 3 things that are necessary to get the oxygen and the nutrients to the cells. So if you have a failure in any one of these, it can lead to shock, a shock syndrome. There are a couple different kinds of general categories of shock. Hypovolemic shock, and this is the most common kind of shock, and this is just basically a loss of fluid. So this is going to be the fluid component. And this, you can lose fluid for a variety of reasons. You can have relative hypovolemia, and that is just fluid loss, and that can be from excessive vomiting and diarrhea. It can be from trauma, exsanguination. It can be in the operating room if a patient is losing a lot of blood in the operating room. If they've severed an artery, so anything like that is a relative hypovolemia. They're losing fluid. In a maldistribution type of hypovolemia, they still have fluid inside the body, like inside the skin, but it's not staying in the vascular system. So really it's ineffective. So this is your patients who are third spacing, your patients who are edematous. So they've got fluid in the system. It's just not where it's supposed to be. And the kinds of shocks that show up here, it's called a maldistribution or a circulatory kind of shock. These are patients who are septic, neurogenic, and you'll also hear this called spinal shock. Neurogenic shock follows spinal cord injury because there is a disruption in the sympathetic nervous system. And if you remember, your sympathetic nervous system is responsible for vasoconstriction. Well, when that is absent, you don't have that sympathetic vasoconstrictive reaction, and so you have massive vasodilation, and that is going to lead to shock. So that's all neurogenic septic shock associated with spinal cord injuries. Anaphylactic shock, that's the one where your patients are having a very severe allergic reaction and massive vasodilation because of an allergen and a severe allergic reaction to some kind of substance. Bee stings, peanuts, there's latex, there's all kinds of stuff that people can have an anaphylactic reaction to. And then there's cardiogenic shock. Cardiogenic shock really now is going to be related to the pump, and you're going to see the cardiogenic shocks occurring in your patients who have cardiac problems. Cardiogenic shock is going to show up in your patients most often following an MI. So you're going to watch, if your patient has an MI, now we're going to watch for them to go into cardiogenic shock. So let's start. I want you to turn to chapter 14 in your book, because I want to go through. I want to point out some stuff that I want you to focus on. So keep in mind that shock is a clinical syndrome. It is a syndrome of inadequate tissue perfusion. That's the problem. And then when those tissues are not perfused like they're supposed to, they go into anaerobic metabolism. They start getting inflamed because they're hungry. They're hungry for oxygen. They're hungry for glucose. So they will go into anaerobic metabolism, meaning, like, if you'll recall from physiology, most tissues like to have aerobic metabolism. They use oxygen, that uses ATP, uses energy. That's how the cell is supposed to work, with using like the glucose and the nutrients that come in, the oxygen that comes in, and the ATP is working fine and releases the energy, and that's how the body works. Well, when those cells are deprived of that oxygen and the nutrients, they go into anaerobic metabolism, meaning they have to produce energy in the absence of oxygen. And then when that occurs, then there's a breakdown in the cell leading to an acidic response. So the patients tend to get very acidic. There's a release of lactic acid. Lactic acid gets released anytime there's anaerobic metabolism. And then the inflammatory process kicks in, because now there is a problem in the cells. So the natural response then is to initiate this inflammatory response. So it's a bit of a cascading situation that starts to occur. So the thing, there's a million different things that can cause shock, and we already kind of talked about that. So I want to direct your attention over to page 287 in your book, and I want you to look at figure 14.1. And this is a normal cell on the left side versus the effects of shock on the right side. That's kind of important to understand that, because that's really what's going on at the cellular level, and this can start occurring in your patient before they ever even start showing a lot of symptoms. So it's really important to be on your nursing game and identify which patients are at risk. So the patients that are going to be more at risk for this are your elderly patients, any of your patients who have any kind of comorbidities. So let's say the hypovolemic patient, your patient comes in, they've just been in a car accident, they have had some trauma, they've had a lot of blood loss. Let's say that they're also overweight and a smoker, and they have high blood pressure and congestive heart failure. That patient now, because of the comorbidities, is at much higher risk for developing a shock state because of hypovolemia. The elderly are at higher risk for developing shock. So anytime they come in, and had surgery, if there's a problem in surgery, if they develop an infection after surgery, and a lot of times, like, the patient will be at home and they will, especially in the elderly, they won't even realize that, hey, they have a urinary tract infection, so it will go untreated for several days. Then it gets into the bloodstream and it's overwhelming, hence the urosepsis. Then the massive vasodilation starts occurring, and next thing you know, the patient is in septic shock. So I want you to go through this and understand the pathophysiology of this. A couple things I wanted to point out. Look down at the bottom where it's talking about blood pressure regulation, and I'm on page 286 right now. See how it's starting to talk about the mean arterial pressure. Remember when we talked about that during hemodynamic week, that it's important to maintain a mean arterial pressure. Now, your mean arterial pressure, if you'll recall, is the average amount of pressure on the arterial side. Now, for some reason, and I don't know why, but your book says that it's really complicated to figure out true mean arterial pressure. That's probably true, but we can sure get pretty close with a pretty simple formula. It's pretty simple. It might not be 100% accurate, but it's darn close. So to figure out your mean arterial pressure, you take your systolic blood pressure plus 2 times your diastolic blood pressure and divide by 3. That's really super simple. So if your blood pressure is 120 over 80, you're going to do 120 plus 180, what did I just say? Wait, 120 over 80, no, that's 60, like that. And then what is that? 280. And then you take your 280 and you divide that by 3, and that comes out to, let me see, 3 goes into 28, 9 times is 27, 10, like 93.33. That's kind of average. So this is not a hard formula, and it's a really good assessment of how adequately those tissues are being perfused. Mean arterial pressure, the pressure coming out of the pump, left side of the heart, because it's really the left side of the heart that's going to get all the stuff, the oxygen, nutrients to the tissues. So you want this mean arterial pressure to be greater than 65. If you have a normal blood pressure, you're at about 93. So you can sort of monitor your patient's blood pressure, which is a super easy number to get. You monitor that, and if it's greater than 65 millimeters of mercury, you're probably getting adequate tissue perfusion. When it starts getting less than 65 millimeters of mercury, then you start worrying that your patient's not getting adequate tissue perfusion, and they could start developing shock. So this is an easy number for you to follow. If you start noticing that this is starting to drop, you start getting a little worried. The other one that's pretty simple is a pulse pressure. Your pulse pressure is just your systolic blood pressure minus your diastolic blood pressure. That's called your pulse pressure. We talked about that during hemodynamic week. When your pulse pressure starts widening, that we worry about that. So, you start out with your, let's say it's 120, minus 80. That's your baseline. But if this starts widening more than like 40 points, you start worrying. So if this one starts going up, like let's say now this is 150, and your diastolic starts going down to 60, Now you have more than a 40-point difference, and now you start getting a little bit worried about that. That's another indication that your vasculature is not able to maintain proper compensatory mechanisms, because when your patient is in shock, it is essential that they maintain adequate compensatory mechanisms. So for example, if your baroreceptors, those are the receptors in your carotid arteries. You've got receptors in your kidneys that are very sensitive to blood pressure and fluid levels. So you've got all of these sensors working in the body, and when those can detect that blood pressure is falling, fluid volumes are falling, then the natural compensatory response is to cause vasoconstriction, because the body is trying to hold fluid in and maintain cardiac output. Heart rate will go up, vasoconstriction will occur in an attempt to get fluid to the vessels. So I don't know why your book says that it's difficult to figure out mean arterial pressure, because it's not that hard. It might not be as accurate as having, like a Swan-Ganz catheter in and getting, exact measurements, but it's pretty darn close. So keep that in mind when you're taking care of your patients. So the stages in shock, I should probably write this down for you. The first stage is the compensatory stage. So as soon as your patient starts developing, any of these problems, the very first thing that the body does is to compensate. We've talked about this all semester long. Compensate. So they do all of the things like when you have dropping fluid, your heart rate goes up, your vessels will constrict, you will hold fluid, all in an attempt. That's just compensation. That's what your body does. The second stage, and this one, you want to intervene here. So you want to give your patients oxygen. You want to give your patients fluid. You want to do things like, if it's a volume problem, you can put them sort of like in a reverse Trendelenburg or a modified Trendelenburg where their feet are up, so that if you've got this massive vasodilation going on, you don't need a ton of fluid in your feet. You need it up in your heart and lungs. So if you put your feet up and it drains the blood back to the heart and lungs. Just simple things during this compensatory phase. And at the same time, like for example, if it's a septic shock, we're going to be given the antibiotics because we're going to try to help that body fight the infection. If it is a neurogenic shock, we're going to want to do things that are going to release the trigger. There's certain things that'll trigger neurogenic shock. Like a full bladder, full bowel, those kinds of things can tend to trigger a neurogenic shock. So if you can remove the trigger point, sometimes that'll help that go away. Anaphylactic shock, you're going to maybe give epinephrine, and there's usually epinephrine. If it's like a snake bite, you can give the toxin or the antidote for the venom or something like that. But typically in an anaphylactic, you'll give like an epinephrine to cause vasoconstriction. And you'll notice, we're going to talk about this in a little bit, a lot of the drugs that we give for our patients that are in shock are the vasopressors. They're the drugs that are actually going to cause vasoconstriction, the epinephrine, dopamine, dobutamine, things like that. So in this first compensatory phase, we're going to help our patient to do what the body does. We're going to rest, good nutrition. Don't avoid the good nutrition because it's extremely metabolically demanding to be in this state. So you don't want them NPO. If you can get them on tube feedings or something like that, so that the nutrition can help fight the inflammatory process and the vasodilations going on, because you really want them to avoid them going into this progressive stage. So stage 2 is progressive stage. That's getting a little bit worse. This is getting into an ominous sign, and it's a little bit more difficult to treat. You have to get a lot more aggressive in this progressive phase. The patient might have to be placed on a ventilator because they're just not getting adequate oxygen. this is when they might have to be transferred to the intensive care unit. You're going to start putting the Swan-Ganz catheters in and the central venous lines in so that you can really monitor the fluid. You can monitor what the patient's blood pressure is doing. And then you really want to avoid this third phase, which is irreversible. At the third stage, which is irreversible, all of the body's natural compensatory mechanisms are absolutely exhausted and they can't do it anymore, and they just start giving up, and then cellular death occurs, and that is what it means. If your patient hits this phase, it is fatal. That is a fatal disease or a fatal process. So you want to avoid them going into shock altogether. So you got to be on your game and know who's sort of at risk for this. Once you see them going into this compensatory phase, you want to help the body. You want to support and give any help that you can in this compensatory phase, because you want to try to reverse that. Once they move into the progressive phase, we're going to get a little bit more aggressive with our treatment, send them to the ICU, and hopefully they won't get to stage 3. The other problem, the other thing in your patients with shock, it's especially problematic in your patients who have adrenal gland insufficiency. And you'll recall some of those, like during endocrine week, patients who have adrenal disorders, because a lot of these vasoconstrictive mechanisms are controlled by the adrenal medulla and the adrenal cortex. Those are sitting on that adrenal gland right on top of the kidney. So anytime your patient comes in and they have a problem, they also have an adrenal problem, they're at more risk for shock. So you have to be careful with that. Okay, what else do I want you to know about this? Do kind of read through where it starts stages of shock on page 287. Sort of read through the different things that are occurring in the compensatory stage. And then on page 290, it talks about the progressive stage and how you need to get a little bit more aggressive, and how the pathophysiology is starting to deteriorate. Like you have much more cellular permeability, meaning that fluid is leaking in and out of the cell when it's not supposed to be. The inflammatory response is starting to kick in. The other thing that you'll see in this progressive stage is clotting problems. And there is something called DIC, disseminated intravascular coagulation. And you will see this starting to occur in your patients who are in this progressive phase. And it is an unusual phenomenon where both increased bleeding and increased clotting is occurring at the same time. So your patients who are in this phase, and you're taking care of them, all of a sudden you might start to notice that their IVs, they're starting to weep around their IVs. They might start having nosebleeds, their gums are going to start bleeding, but at the same time they're also developing little micro clots and microembolisms. So now your patient's at risk for DVTs, strokes, things like that, because they're also having a clotting problem. So you can have some complications in the progressive phase that can be very serious. So this gets a little tricky, because they might have to be on heparin to avoid the clots, which really is counterintuitive because they're also in a bleeding situation. So oftentimes you might have to get hematology involved to follow this DIC problem. And you would treat them like a hemophiliac. You need to be very careful that you're not excessively sticking them with needles and excessively going to testing and things like that, because they can have a bleeding problem. Okay, and then over on page 292 talks about the irreversible stage, so hopefully we're going to try to avoid that. Your fluid replacement, I just want to point this out. We talked about this during Fluid Electrolyte Week, but remember that your crystalloids are that's your IV fluids. Those are just sterile water with a little bit of something else added. 0.9 normal saline, a little bit of dextrose, lactated ringers. They're cheap. and you can give high volumes of them. The problem is if you have to give high volumes, you can fluid overload your patient. They can start having pulmonary problems and congestive heart failure if they get too much fluid. But if they don't get enough fluid, then you're not getting good tissue perfusion. So the other fluids that you can give are the colloids. Those are they're more expensive, but they are the blood products, the plasma, albumin, things like that, packed red blood cells. And your patients, especially if they move into this progressive phase, are probably going to need to start getting some blood replacements and some colloid replacements. So then, I wanted to point out something else. On page 294, look down where it starts talking about your central venous pressure, because this is, if your patient moves into this progressive phase, this is when you also need to start monitoring their hemodynamic status. What is their central venous pressure doing? What is their pulmonary artery wedge pressure doing? What's their afterload? What's their preload? You kind of have to start monitoring some of those so they're going to get some more of those invasive lines in. Here's the problem. On page 294, about halfway down, you will see that it says a normal CVP is 4 to 12. Well, you may recall, if you remember this, when we did hemodynamics over on page 687 in your same textbook, it says that normal CVP is 2 to 6. And this is why I keep telling you the CVP number changes a lot from person to person, textbook to textbook, and facility to facility. So really, 12 is actually getting a little bit high. If you sort of remember that your central venous pressure should be between 2 and 10, that's sort of an average, a safe average, but you will see this number changes quite a bit. But what you do want to get is, like, you get your baseline central venous pressure and then monitor it with other readings, so you can kind of trend, is my patient going up or is my patient going down in their fluid status. So I just wanted to point that out. The other thing, I wanted to talk a lot about the medications, because there's this vasoactive medication therapy down here at the bottom. There are some medications that are really important in this category that increase the contractility of the heart. They will decrease afterload or increase afterload depending on if your patient is vasoconstricting or vasodilating, what phase they're at, and regulating the heart rate. So I wanted to point out up here at the top of page 294, I do want you to know these vasoactive medications. You've got alpha adrenergic receptors, and then you have beta receptors, and the beta receptors are a beta 1 and a beta 2. Hopefully you're learning about that in pharmacy. If not, let me know in class and I'll explain it to you a little bit more. But your alpha adrenergic receptors, they will constrict blood vessels in the cardiopulmonary, GI, skin, and things like that. And then your beta 2 sometimes it causes vasoconstriction, but then in other areas it causes vasodilation, causes the bronchioles to relax, which is why some of those medications can also trigger some, like a cough and some asthma. So you might put your patient, a hypertensive patient, on a beta 2 blocker, and because it helps, it causes vasodilation, so it'll reduce blood pressure, but it also causes the bronchioles to dilate, and then it can start causing some like asthma kind of symptoms. So you just watch for that in your patient who is getting beta 2 drugs. So the other thing I want you to know with these vasoactive drugs is table 14.2 on page 296. Those are really, really good drugs to know, because you need to understand, like the inotropic agents up there at the top, those are going to do things like increase renal perfusion, increase systemic vasoconstriction, because you want the systemic system to vasoconstrict so that it will shunt the blood back up to the vital organs, the heart and lungs. dobutamine, dopamine, epinephrine. Those are your big guns that are, we call those the vasopressors. They help, they're positive inotropic, so they're going to help increase the contractility of the heart. They're going to cause vasoconstriction because shock is a massive vasodilation situation. But sometimes you need to give things like epinephrine and stuff, that's or nipride or some of the vasopressor agents to increase blood pressure by vasoconstriction. So look through that table up there on page 14 too. And then the next part in your book talks really about the different kinds of shock. So the first one is hypovolemic shock, and this just gets into the specifics of each of the kinds of shock. So, but do read through that. Like for example, cardiogenic shock on page 298. The problem with cardiogenic shock that you have to worry about a little bit more than the other ones is that it can also lead to some of the dysrhythmias, and the lethal dysrhythmias like, you know, VFib, VTAC, things like that you have to be careful of in your patients who have cardiogenic shock, which is not as likely in the other kinds of shock. So do, like, look at page 299 where it talks about first line treatment, oxygenation, pain control. These patients start getting very anxious because they know they're very sick. And the family gets very anxious. So you need to give the patient pain control, maybe some anti-anxieties, get some help in for the families, because the families will start watching this patient sort of deteriorate, and it's a little bit scary. The labs, we talked a little bit about hemodynamics with preload and afterload and systemic vascular resistance. Hopefully you remember that from hemodynamics. If not, we'll go over it again in class. The labs you're gonna get for your patient, especially in cardiogenic shock, if you recall, remember we talked about the beta natriuretinic peptide, the BNP. Some people it's called the brain neutropenic peptides. The cardiac enzymes, the troponin levels, the bands. Those are the ones you're going to get in your patients who have cardiogenic shock. And then you can just, I want you to read through the rest of this, like septic shock, we talked about, that's just a widespread infection. Those patients are going to be on antibiotics. Your other patients like cardiogenic and hypovolemic, they don't need antibiotics. So this is when it kind of gets important to know what kind of shock your patient is in. Then what can happen if your patient is developing shock and it goes untreated, and it is the compensatory phases are starting to fail, then the patient can start developing two different things. One is called SIRS, S-I-R-S, is Systemic Inflammatory Response Syndrome, and the other one is MODS, Multiple Organ Dysfunction Syndrome. When you see SIRS and MODS starting to develop in your patient, those are ominous signs. Those are typically, your patient is in a progressive stage and they're getting very close to that irreversible stage, because what that means is that now you're starting to develop multiple organ failure. And that's never good. So when you start seeing a decreased urine output, increased pulmonary problems, increased fever, lethargy, things like that, now you're developing multiple organ dysfunction syndrome, and that's an ominous sign. So you can read, there's just a little blurb on systemic inflammatory response. That one can occur in any of the shocks. Neurogenic shock, I already talked a little bit about. In neurogenic shock, the spinal cord injury, the spinal cord injured patients, the sympathetic nerve runs through the spine, and in the event that spine gets severed, then all of a sudden that the sympathetic, it's down at level T something, T7 I think is where the sympathetic nerve comes out. It's down in the T's. I can't remember. I think it's level T7. You know, you got your cervical, lumbar, and then your thoracic spine, and that sympathetic nerve goes right through that spine and comes out at T7. Don't quote me on that. So when the spine is severed higher than that, well, then that sympathetic nerve, which is responsible for speeding everything up, it causes vasoconstriction, it causes increased heart rate, it causes increased blood pressure, all the stuff that you need in that fight or flight response. That's what your sympathetic nervous system does. Your parasympathetic nervous system goes on the outside of the spine, and that's the counteracting effect. So, and they kind of work in balance. So if your heart rate gets too high, then the parasympathetic system kicks in and brings it back down. But if you don't have those opposing forces, so the patient can get massive vasodilation with there's no countermeasure to cause vasoconstriction. And so that's what occurs in neurogenic shock. Obviously you want to try to avoid that, but be aware of it when it's occurring. Then you have to increase fluids and things like that. Anaphylactic shock we already talked about. Now on page 306 is the multiple organ dysfunction syndrome that I told you about, so you can sort of read through that, and that's it. So that's really what you need to know about shock. Basically watch for it and identify it and fix it ahead of time, because you really want to avoid shock if you can. And once you've identified that shock has occurred, you want to treat it and get it under control at the compensatory phase, so that you don't go into these other phases, because it can get a little bit tricky to treat. So that's it. Okay, see you in class.